Hello, my name is Lukejohn Welch, and I am an assistant professor of medicine at the San Francisco General Hospital and Trauma Center. Today I want to discuss our paper entitled Optimizing Efficiency and Operations at a California Safety Net Endoscopy Center, a Modeling and Simulation Approach. There has been a dramatic rise in the requests for gastrointestinal specialty care, and in particular endoscopic services in the last decade. This increase has been most notable in safety net hospitals, whereby GI is the most frequently requested specialty service. At the same time, access to specialized GI care can be challenging within specific healthcare systems, such as the safety net. Such disparities highlight the need for innovative ways to increase access to GI care for underserved patient populations in light of increasing demand. Improving efficiency with endoscopy centers may help with expanding access and throughput, yet there is limited data in this area. Time and motion studies and discrete event simulation modeling can be used to evaluate alternative care delivery systems, identify bottlenecks, and enhance overall efficiency. Our first objective in this study was to conduct a time and motion study of clinic staff at work and to use this data in simulation modeling to study changes in scheduling, staffing models, and changes in the pre- and post-procedure process. Our secondary objective was to build a simulation model to understand the bottlenecks limiting the endoscopy center's current operational performance, and in turn, to identify opportunities to improve patient throughput. There were three phases of our study. First, we conducted a time and motion study of the San Francisco General Hospital and Trauma Center Endoscopy Center in order to better understand the operations and processes of a safety net endoscopy center. Second, using information from this study, we then created a discrete event simulation model to assess proposed changes to the endoscopy center in order to improve efficiency within it. The final phase of the study involved implementing some of the proposed changes at the SFGH Endoscopy Center and examined the impact of these changes on a number of performance metrics. Data of our study were collected on 278 patients. First, time and motion study revealed that 53.8 procedures were performed per week, with patients spending 2.3 hours at the endoscopy center. By using discrete event simulation modeling, a number of proposed changes to the endoscopy center were assessed. Decreasing scheduled endoscopy appointment times from 60 to 45 minutes led to an increase in the number of procedures performed per week, but also increased patient wait time. Also, increasing the number of endoscopists by one each half day resulted in increased procedure volume, but at the same time, there was a concomitant rise in patient wait time and nurse utilization exceeding capacity. By using the data gathered and information learned from each simulation run, a number of individual scenarios were then expanded and combined. The greatest improvement in performance metrics was created by moving patient endoscopy appointments from the afternoon to the morning. In this simulation, at 45 and 40-minute appointment times, procedure volume increased by 31% and 52%, and patient time spent in the endoscopy center decreased by 17% and 13% respectively. Lastly, we implemented 3 of the combined scenarios in our endoscopy center and examined several performance metrics. The predictions of the simulation models were found to be accurate when compared with actual changes implemented in the endoscopy center. In summary, through observation, time and motion study, and discrete event simulation modeling, we demonstrated that in a large, diverse safety net hospital endoscopy center, that weekly patterns, although variable, are predictable and provide insight and recommendations as to what potential changes are beneficial. We illustrate that patient throughput, as well as provider and nursing utilization, are substantially increased with only simple changes such as decreasing endoscopy appointment times, realigning the endoscopy schedule with patient preferences for early morning appointments, and minimizing and streamlining the recovery room and pre-procedure process. Additional improvements in throughput are possible, but only with additional costly human resources, overutilizing nurses, and unacceptable patient wait times. Our study is unique in that we involve clinical staff in developing and testing changes, while other studies generally utilize GI data and then work on it separately from providers and staff. Additionally, we are the first to use such methods to examine efficiency and change in a large safety net endoscopy hospital system with significant training involvement. Overall, in a resource-limited setting, we discover that understanding patterns and behaviors can be used to develop solutions in a cost-effective manner.